Uh, good evening from Nepal. I am Dr. Pradeep, and I am working as a pediatric fetal radiologist and assistant professor in Tribhuvan University Teaching Hospital, Kathmandu, Nepal. And today my topic of this lecture as a facilitator is clinical relevance of obstetric ultrasound and why we do obstetric ultrasound, what are the key points we extract from regular workflow so that it will be benefited for the patients. So let's move on. So today's outline will be a short introduction about myself and my institution and a short history of ultrasound and how it works and understand the key indications of obstetric ultrasounds in clinical practice and recognize the trimester specific applications of obstetric ultrasound, what clinicians need in each trimester so that it will be benefited for the patient management and appreciates the ultrasound role in improving maternal and fetal outcomes, and lastly, take-home message. So I'll be discussing this within this 40 minutes of my lecture. So as you know, Nepal is situated between India and China, uh, and it is a landlocked country. And the shape of Nepal, and in northern side, it is full of mountains like Mount Everest. And the flag of Nepal is also unique. It is a triangular shaped one. And this is my workplace, Tribhuvan University Teaching Hospital in Nepal. It is the largest hospital in the country, largest referral center. So, and our department conducts, we have 9 ultrasound units for the outpatient, outpatients, and emergency. We have 1 ultrasound machine, and we have CT scan, 3 CT scanners, 3 MRIs, fluoroscopy, X-rays as well as, and we also do academic program. We also conduct academic programs as well. We have residency, fellowships, and master's and bachelor's level programs for technical students and certificate level courses as well. So in diagnostic, we have now running 3 fellowships, women's imaging and musculoskeletal and body imaging, and upcomings are other like neuro, pediatrics, cardiovascular, as well as intervention as well. So, and we have a separate research unit in the department, and we have a separate core team for the research so that it conducts the research within the department. And under the leadership of HOD Professor Dr. Kansam Gurung and Associate Professor Sharma Paudel, we are conducting different artificial intelligence in fetal imaging projects under Gates Foundation in collaboration with NAMI in Nepal. So my TUTH core team is another Dr. Prajwal Dhakal is also actively involved, and we have research assistants Amrita and Rina as a regular member in our research team, and this is my department as a whole. And so now coming to the core topic of today, ultrasound. It is a non-invasive imaging modality, and it is the gold standard for pregnancy assessment, and it is widely used for diagnosis and monitoring throughout the pregnancy. And how it works, it is based on the name itself, ultrasound. It is frequency above the audible sound, so we cannot hear that sound. And medical ultrasound is about 1 to 20 megahertz, uh, which is significantly above the limit of human hearing. So, and how it works? When you keep the transducer, I will make my pointer. So after the transducer is kept on the patient skin, as shown in this image, we put a gel because it reduces the scatter of ultrasound waves so that it can be focused in the patient's abdomen. And there is a skin layer. So there is a gel between the transducer and the skin layer. And then the ultrasound, the original wave from this ultrasound transducer machine is transmitted to the patient's body, and then it is reflected back into the transducer so that the image can be generated into the ultrasound machine. So a bit in depth, when the electrical impulses are passed through these piezoelectric crystals within the transducer, it transmits ultrasound wave towards the organ, and then the organ in which we are imaging reflects back the ultrasound echoes from that organ and to the piezoelectric crystals, so that it can be transmitted electrically into the display machine of the ultrasound. So this outlines the principles of this ultrasound, how it makes the images. So in clinical workflow, in practical, we have got three variations of ultrasound machines, and this is the bigger one, which is a bit more expensive as well. And this is a static unit which we put in regular OPD setups as well as emergency. The middle one is commonly used in ICU setups for portability, and the other one is more portable devices, which can be utilized as point of care devices in the peripheral setup as well. So it is quite easily transferred to the other places, as well as it is more cheaper than the other two. And the transducers probe are also different to image the different anatomical structures. And the first one is the deep, we call it curvilinear ultrasound probe, which has more depth penetration, so that we commonly used for the obstetric ultrasound as well as normal abdominal ultrasound. And the other is the linear probe on the right of the image, and it is used for the superficial structures like artery, vein, and nerves for this. And the other third one in the lower side is the sectoral probe, which is commonly used for adult echo as well, and long ultrasound as well. And the other is the transvaginal or transrectal probe, which is used commonly for the pelvic imaging in women for uterus and ovaries, and prostate commonly for men. So these are the four types of probes which are available commercially, and we are using this probe in regular day-to-day activities. And these probes are usually different frequencies, so that they can be higher the frequencies, greater the resolution, and lesser the depth. So the curvilinear probe has the higher frequency, and it has the greater resolution, and it is used predominantly for the small parts, superficial parts, like I already said, vascular structures or musculoskeletal structures. So these are the four different probes with different frequencies, and the target of images are different organs. So we have to remember that lower the frequency, greater the depth. So it is most important in obstructive ultrasound. Lower frequency like 2 to 5 megahertz with greater depth penetration. And coming to the orientation of probe, each probe has small knob, this black structure, which is used for our it should be always in the patient's right side or in the upper in the direction of head. So while doing the longitudinal scan, this knob should be placed on the upper side, and while doing the transverse scan, it is always placed on the patient right side. And brief history of ultrasound, we have come so far from 1940s, which inspires the medical imaging, which has in the past we have static ultrasound images which can, and 1950s, and Donald, pioneer of obstetric ultrasound, came up with these first fetal measurements. Then coming to 1980s, started the Doppler studies and anomaly detection. Now dynamic fetal observation is also in different aspects like 3D ultrasound, 4D ultrasound. And after 2000s, there are this is a hot burning topic in obstetric ultrasound. It can be used as in portable ultrasound devices as well. And after 2000, there is AI-driven image analysis from this obstetric ultrasound as well. And the other separate entity is contrast enhanced ultrasound, which is also one of the emerging technology especially in pediatrics, which is equivalent to contrast CT abdomen for visualization of the liver masses as well. So contrast enhanced ultrasound is also quite commonly used in US and Europe also. So coming to the obstetrics, use of ultrasound in obstetrics can be approached in two different ways. Like in first one, we can approach what are the important things uh, occurring in obstetric during the pregnancy, so that you can pick up that emergency situations from that pregnant woman to help the clinicians. And so it can be divided into emergency or non-emergency scans. And other way to approach is trimester wise. First trimester, what are the things you need in first trimester? What are the things you need in second trimester? And what are the things you need in third trimester? So I will go in detail with these trimester specific ways, so that we can know that the exact clinical relevance of obstetric ultrasound, what the information we want to get from this trimester specific approach. So in first trimester scan, we usually do uh, dating or viability assessment, which we call it when the mother knows that she is pregnant. She comes. This is the one of the indication to do ultrasound. So obstetrician send us for the scan, and we measure crown rhomb length. It is the full length of the baby within the uterus. This black part is the cavity, and the peripheral part is whole the uterus of the mother. So it is the CRL, crown rhomb length. It is measured from head to the buttock level of the fetus. So we usually measures crown rhomb length till 84 mm of length, and it is usually about in first trimester of pregnancy. And another, we measure fetal heart rate, and by the automated machine we get the expected date of delivery from that CRL. And we also look for the bilateral ovaries and screen the upper part of abdomen. So this is the basic thing we do when patient approaches to us for the first trimester scan in the first, when she knows she is pregnant. And in early pregnancy, there can be different challenges. There can be sometimes the embry- this is the embryo, which we can see in approximately 6 weeks of age, and this is whole is the uterus, and this is the sac, and this is the arrow shown is the embryo. So we measure the length of the embryo, which is we call it CRL, and there is it will be corresponding to the weeks of the fetus, and this is the embryo, and this is the yolk sac, and this whole is the gestation sac, and this is the uterus. So in first trimester early scan, we look for these structures within the pregnant uterus. And fetal heart rate is usually measured with the motion mode, and we measure while we put on the motion mode, we will see this line, and we measure the fetal heart with this uh, uh, wave. Either you can measure trough to trough or in the peak of the wave as well, two peaks of the wave as well. And sometimes there are challenges that you cannot see the embryo of the embryo within the early pregnancy if the fetus is usually less than 6 weeks. So in abdominal scan, you can see the fetus after 6 weeks, but in transvaginal scan, you can see in the cases of less than 6 weeks as well. So if you do not see the embryo, only you see the sac and the yolk sac. Commonly we do is go for transvaginal scan to confirm whether there is a embryo or not. And if there is no embryo in transvaginal scan, we again follow up after 2 weeks for fetal viability. Then only we confirm that this pregnancy would progress or not. So these are the important aspects. And another important emergency condition is ectopic pregnancy. Ectopic pregnancy means that this is the normal pregnancy. You can see the fertilized egg is within the uterus. And in contrast, you can see in the other images that the embryo is within the fallopian tube itself. It is not in the uterus. So it is one of the emergency condition. It can rupture and create the large amount of blood will be collected in the maternal abdomen, and she can she can deteriorate and she can land up in emergency and ICU as well. So she needs emergency operation. So it is one of the important aspect we can pick from artificial intelligence as well. So many of the projects you can find in internet, they are running that in first time early trimester, if it can be picked in early pregnancy as well. So there are some projects as well. So ectopic pregnancy is one of the life threatening, and it is one of the important diagnosis which helps the clinician or the mother to save life of the mother due to large blood loss from this ectopic pregnancy rupture. So if the ectopic pregnancy, if you suspect the uterus is empty, and if you find some cystic structure in the uh, at the side of the uterus, if the mother is pregnant, you must suspect ectopic pregnancy. So uh, we get this is the common case we can get in the emergency setup, and if you are lucky, you can see the heartbeat within that ectopic pregnancy as well sometimes, if it is not ruptured. But many of times you will get only the hematoma collected at just beside the empty uterus. So we suspect it is ectopic pregnancy in UPT positive pregnant ladies. So the expected location of ectopic pregnancy can be either in the cervix or in the bilateral adnexa, meaning that sides of the uterus and outside the pelvis, or you cannot say whether it is ectopic or so this unknown location can be successively follow up with after admission of the patients with ultrasound and transvaginal scan as well. So the other thing we do in early pregnancy at around 11 to 14 weeks is nuchal translucency scan, and it is one of the marker for trisomy to rule out Down syndrome, and it is the fetus of approximately 12 weeks, and in this week we usually measure uh, nasal bone. You can see this arrow, it is the nasal bone, and another is on the back of the neck of the fetus, it is the nuchal translucency. So uh, commonly, if it is more than 3 mm, we suspect for trisomy or Down syndrome. So the mother gets another dual marker scan in blood as well after we suspect this. And we usually measure CRL till this week, 12 weeks, so that. And coming to second trimester, revising in first trimester, if the pregnancy is suspected, we do fetal scan measuring crown rump length. And the early anomaly we do in the first trimester is nuchal translucency and nasal bone. So coming to second trimester, main goal is to define the fetal anatomy in 18 to 22 weeks and detect any congenital anomalies are there or not, and localize placenta and amniotic fluid. We also look for the amniotic fluid if it is adequate or not. So to determine this fetal growth and fetal anatomy anomalies, what we usually measure are biparietal diameter, head circumference, cerebellar diameter, abdominal circumference, femoral length, and after we measure these four things, it comes expected fetal weight, which is EFW, and amniotic fluid we measure in the 4 quadrant or in the maximum vertical pocket as well. So I will show this one by one. So in second trimester, we usually measure biparietal diameter, which is we uh, go to the plane of this cranium. We have definitive plane for this. We have the certain landmarks where we have to measure this biparietal diameter, and we measure from the outer end of the cranium to other side, the inner end of the cranium. So it is biparietal diameter. The other thing we measure is head circumference, which is the outer circumference of the head. And other thing, this is abdominal circumference. We measure is the abdominal circumference of the fetus. And we have also certain landmarks for this. This is the fetal stomach, and this is the portal sinus, and the other is the femoral length. So after these four things we measure in second trimester, we get expected fetal weight. So that in this fetus we get it is about 21 plus 6 weeks, and expected fetal weight is 392 grams. So after we measure this, we can get the idea of the growth of the fetus if it is according to the weeks of the uh, mother as well. So in this way we measure this. So biparatal diameter we measure in outer to inner on the other side with the axial plane, which must have the thalamus and septum pellucidum like the bow arrow. In this landmark, we usually measure biparatal diameter, and these two hemispheres should be symmetric. So after we measure this, in this case, it is 4.7 centimeter corresponding to 20 plus 3 weeks. It is the automated measurement we get from the Hadlock method in uh, um, the application installed in the ultrasound machine. The other is head circumference. As I've already explained, it is the outer circumference of the cranium. And like this, we get this 20 plus 3 weeks in this case. And this should be symmetrically oval. And there are certain anomalies which we cannot see this calvarium nicely. So this can be, and after this, we go to measure the abdominal circumference. In this abdominal circumference, we have to see the stomach and portal sinus. We measure the uh, abdominal circumference this way, and outer to outer circumference we measure, and then we get the corresponding gestational age uh, of the fetus. And femoral length, we measure this femur length throughout in the uh, clear transverse image, and end of the bones should be blunt, not pointed. And if there is excessive bowing or demineralization, we never measure that portion of the femur. So transducer aligned along the long axis of the bone, so it gets perpendicular to the shaft, and it is the ideal image to measure the femur length. So there are certain anomaly guidelines how we do the anomaly scans during fetal anatomy scan. We measure these approximately. There are 20 plus 2 planes correspond referring to this article, and with this 20 plus 2 planes method, we can identify 65 fetal abnormalities during our second trimester anatomy scan. So during the scanning of the child, we can see this. We measure this way the cross sectional of the fetus, biparatal diameter, and the head circumference, and we measure the spine along the longitudinal length, and we measure the heart, chest in the axial plane, and abdomen through the axial plane, and comes the urinary bladder as well. And this is the graphic representation how many planes we usually scan during the fetal anomaly scan. And the scanning planes for the upper limb and lower limbs are also, we have to make the shaft of the bone perpendicular to the transducer plane so that we can see whole length of the bone. And this is the measurement of the biparatal diameter, and the cerebellar diameter we measure this way. And the other is we measure the fetal face as well, and we measure the fetal face in two planes, one axial plane and another is the facial profile view, so that we can see the fetal nose as well. So in this way, there are 20 plus 2 planes we measure. So while doing anomaly scan, we see the spine throughout its length in second trimester, in the sagittal plane and coronal plane as well. And we see the coronal length of the full body as well to see the diaphragm, fetal lung, cardiac activity. So these are the common planes, and it is we measure the ventricular diameter as well to identify whether the fetus has ventriculomegaly or not. And this is the biparatal diameter I saw in the last slide, and this is the cerebellum which we see in the fetal head. So these are the common planes we measure, and there is we usually focus on heart as well, chest, and this is the fetal chest, and this is the fetal lung. And during pregnancy, the fetal lungs are solid, and after birth, only the air gets into the lung in the child first breath, so that we can see the air afterwards. And this is the four chamber heart we see, and in different planes we see the heart. And this fetal echo is one of the common thing we do in our regular practice, and it is also one of the aspects where artificial intelligence can also play a role to detect fetal congenital cardiac anomalies as well in fetal heart. So many a times it is harder to get all these planes of the fetal heart. So if we can recognize this, get this 3D segmentation after getting one plane, it is so easy to diagnose congenital heart anomalies in fetus. So it is one of the aspect we can delve upon. And another is fetal abdomen, and the other is the fetal umbilical cord, where the cord enters the abdomen. And these are the fetal kidneys we measure in the while doing the fetal anatomy scan. And all these planes, so if I go in detail, it can be boring. So these are all planes which we can detect during our fetal anatomy scan. So, and these are the fetal look. This is the fetal nose. This is the lips, upper lip, lower lip, and chin. And these are the fetal globes orbits. And this is the nose, and this is the fetal nose, nasal bone, maxilla. This is the mouth. So we usually scan these for the anatomy scan. And for third trimester scan, we usually focus on abdomen, fetal weight, and placenta, and fetal position, and the amniotic fluid volume. These are the five things we focused on third trimester exam. So position of the fetus is important for determining the mode of delivery in the third trimester. So this is the normal uterus in a non-pregnant, and this part is the cervix, and this part is the cervix in pregnant patient, and this is the fetus. So during the birth, this cervical canal opens, and we usually measure this in second trimester to determine if there is any cervical incompetence as well. So it is one of the important aspects to determine cervical status while doing the ultrasound scan. So it is one of the thing that our AI can automatically measure from these sweeps of the ultrasound, so that it can be easy to identify the cervix while doing the scan as well. So this cervix is quite important during second and third trimester. And shape of the cervix is quite, if it is visible all the time, it is important in second and third trimester, because if the cervix starts to open, it can be signify that the fetus can be can be delivered early, so it can be preterm pregnancy. So it can lead to cervical incompetence as well. So it can be alarming situation during the second trimester. So while we do the scan in second trimester, we must focus on cervix as well. So the shape of the cervix can be important during second trimester scan. If the cervix is U or V-shaped, that can be alarming to the clinician, so that it can tie the cervix for preventing cervical incompetence during the second trimester. And if they find this incompetence during the second trimester, the usually obstetrician tie the cervix so that the incompetence can be prevented. And the position of the fetus is usually determined by the location of the head and the cervix. And if the head is near the cervix, it is called cephalic presentation. And if the head is away from the cervix in the upper part of the uterus, it is called breech presentation. And if the head is on the either side or left or right side of the maternal abdomen, it is called transverse. And if it is not directly perpendicular to the cervix, it can be oblique. So this is one of the aspects which must be seen and reported to the clinicians, because it is one of the important determining factor for determination of modality of birth in the third trimester. So we must report this case in our write this case in the report. And another is the amniotic fluid volume. There are two ways of measuring the amniotic fluid. One is four particle pocket in the four quadrant of the maternal abdomen, uterus, and we measure this way. We do one quadrant, second quadrant, third and fourth, and we total it. And if the normal range is 8 to 25 centimeter, it is in centimeter, the vertical distance from the uh, one end of the uterus to the other end. So it must be vertical, and there should not be fetal parts within that measurement position. So we get it total amniotic fluid index in centimeter. And the other is placental location is quite important, because uh, if this placenta is near the cervix, uh, it is called placenta previa. So it can prevent this, um, uh, and it can predispose to the bleeding per vagina during the pregnancy. And even if it is not treated in time, it can lead to fetal demise as well, because the placenta is the source of nutrients, oxygen to the fetus. So, and we determine the location of the placenta in this way. We usually keep the probe on the maternal abdomen, and if it is close to the probe, it is called anterior, and if it is further away from the probe, it is on the other side across the fetus, then we call it posterior placentation. And sometimes it is not clearly anterior and posterior, it can be on the lateral wall of the uterus, either can be right lateral or left lateral. So we usually say that placental location in relation to the cervix as well, just like fetal presentation. And if it is more than less than 2 centimeter from the cervical opening, then we call it placenta previa. So in this case, we can see this placenta is far from the cervix, so it is normal. And it is and in this second case, we can see that the placenta is near the cervix, just reaching the cervix, so it is low-lying placenta. And if it is completely covering the cervix, we call it complete placenta previa. So it is one of the important aspect we detect during the second and third trimester scan, which is, I think, in my opinion, is the most determining factor for normal vaginal delivery or the cesarean section as well. So we must see the placenta clearly. So this is the cervix, and in this case, the tip of the placenta is uh, less than 2 centimeters, so it is low lying, not covering the cervical os. So, and in this case, this is the cervix, and the placenta whole is covering the cervical opening. So it is complete placenta previa. So it is the important thing we report to the clinicians. So, and we finally get the report this way. And in this way, in this report, we usually there is gestational age, expected fetal weight, and all the measurements. And we usually look this gestational age measurement if it is corresponding to the maternal age of weeks of pregnancy as well. So it helps to determine us about intrauterine growth restriction as well. So we can get a complete report, and it is usually plus minus 300-400 grams expected fetal weight, and it depends on the machine as well. And fetal cardiac activity we measure with the M mode, and it is usually 120 to 160 beats per minute in fetus. And if it is less than 110, we call it bradycardia. If it is more than 180, we call it tachycardia. And it is also quite important because if there is some placental compromise, the fetus can land up in tachycardia. So if the fetus is tachycardic, we usually report it is emergency. So it is also one of the important relevance of fetal cardiac activity during clinical ultrasound. Coming to Doppler, Doppler is usually measures the velocity of the blood flow within the arteries or veins, any vessel. It is it lies on the basic principles of Doppler effect, and also the transducer and the artery. For example, in this, if the transducer is if the artery is going towards the transducer, it gives a red color in Doppler, and if it is going away from the transducer, it gives blue color. So uh, blue color is away, red color is towards the probe. And we measure the Doppler shift, and we get the velocity in this curve with systole and diastolic flow. And there are normal reference values in each trimester of ultrasound trimester, so that we can say it is normal or abnormal. So Doppler study, we usually do Doppler studies in umbilical arteries. This is the commonest Doppler we do. And we measure the flow in the umbilical arteries, and we get this type of wave. And we measure resistive index usually, and it is usually around 0.6 to 7 usually, and yeah, in the umbilical arteries. And if it is abnormal, the flow, diastolic flow will be reduced. Then we suspect any abnormality for the maternal side, like preeclampsia with increased blood pressure in the pregnancy, so that it can the flow is compromised within the fetus. So it is also one of the important measurement we provide to the clinician to determine the status of the fetus in third trimester. And another is middle cerebral artery Doppler. We do usually in combination of umbilical artery and middle cerebral artery. And we determine the ratio of the cerebral placental ratio. And if the ratio of the PI of pulsatility index of the middle cerebral artery and umbilical artery is more than 1, then it is normal. So the and the other is uterine artery Doppler, and it is quite usually there are lots of projects going on this uterine artery, because in early second trimester, if the uterine artery flow is abnormal, we can predict preeclampsia early. And there are also certain blood parameters we can measure to to predict preeclampsia. So we can this uterine artery also Doppler is also one of the important aspect we do usually in early second trimester. So it is also one of the thing. Many AI projects are also been done currently in this uterine artery Doppler study in correlation with the blood investigation factors. So in normal uterine artery, we have certain resistive index, pulsatility index, normal range according to the trimester, and uh, this notch is abnormal uterine signifies the abnormal uterine flow during the second trimester. So it is one of the alarming situation. We provide this information to the clinicians uh, in second trimester ultrasound. The other is Doctor's venosus, and it is the early anomaly scan. We do in early anomaly scan to screen trisomies and like Down syndrome as well. And we get this sort of flow in Doctor's venosus waveform. And we usually, this is the normal SVDA waveform, and if it is abnormal or the reversal way, then it is uh, kind of concerns regarding intrauterine growth restriction or fetal cardiac compromise, signifying that that fetus can have Down syndrome. So these are the common uh, parameters we provide to the clinicians. So during this trimester scan, there are certain things. As I say, in first trimester, we usually measure CRL and early anomaly scan we do. And second and third trimester, we measure the four important factors: biparietal diameter, head circumference, abdominal circumference, fetal cardiac activity, and placenta. And uterus, like cervix, and the presentation of the fetus and placental location is also quite important. So these are the clinically relevant information that we radiologists can provide to the obstetrician. So this is the summary that from this first lecture today I have given you. So any questions are highly welcome. Thank you.
All right. I hope you can hear me, Pradeep.
Yeah.
All right. Thank you. So thank you so much. You are receiving some applause from the participants. There are a couple of questions that came up, actually two main questions.
Mhm.
The first was, why do ultrasound images have a conical shape?
Not every, like I said, there are different kind of probes, and curvilinear probe that I saw during my presentation is used for the obstetric ultrasound. So most of the obstetric ultrasound is from the curvilinear probe, so that the sound waves which go through the piezoelectric crystals from that probe is looks like conical in shape in this scan. So if we do from the linear probe, we can get the rectangular shape. So it depends upon the shape of the probe which we use according to the organ which we have to look for. So it depends upon the shape of the probe.
All right, thank you, James. I think that answers your question. The other question is in regards, actually, that was the only question. I'm sure that there's
Mhm.
any other. When and why do RI and PI?
Mhm.
Yeah,
Oh,
yeah.
okay. Resistive index is usually there. It will be a bit in depth, but I have to explain this. Uh, while you measure the Doppler, we in any artery or vein, we get systolic and diastolic flow. Like when we measure blood pressure, we get 120 by 80. 120 is the systolic, 80 is the diastolic. So RI resistive index is the difference between that systolic and diastolic and divided by systolic. So we get resistive index, so that the resistance of the artery is indirectly judged with that. And as we go from first trimester to third trimester, the flow of the vessels, the uterine artery gets wider and wider, larger and larger, so that the resistive index will decrease. So greater the flow, the resistive index is low, and lesser the flow, resistive index will be high. So it is we have to index usually measured in comparison with middle cerebral artery and umbilical artery, so that we get to know about the differences between the flow between that two arteries. So these two factors is usually generated automatically if we have diastolic and systolic flow in the ultrasound machine.
Right, thank you. And then one other question. What is the earliest time we should expect a fetal heartbeat?
Earliest, okay. In transabdominal scan, we get fetal heartbeat around 6 weeks in average. In transvaginal scan, we can get as early as 5.5 weeks of age of gestation. So uh, the usually if we do abdominal scan in 6 weeks, if we do not see the heartbeat, we usually go for transvaginal scan to clear that if the embryo is there and heartbeat is there or not. So we do you can remember 5.5 weeks you can see the fetal heartbeat.
All right, so I think those are all the questions from this. Thank you so much.
What the AFI, another question is
Oh,
that
there's another, yes.
what the amount of AFI in normal pregnancy? There is always confusion. 28. Oh, usually the normal range of amniotic fluid index is 8 to 25 centimeter, 25. And if it is less than 8, we call it oligohydramnios, inadequate. And if it is more than 25, it is polyhydramnios, excessive.
All right, so I think those are all the questions. So we can begin the next session.
Okay.
You may share your screen.
Mm. Integrating, interpreting. I'm opening my second presentation.
Not a problem.
Is it on?
Yes, you can see it. It's not yet full screen.
Okay. Now,
No, it's good.
okay. So this after we in last 30 40 minutes we discussed about clinical relevance, and the second topic after discussing about this relevance, how we can interpret these artificial intelligence models in our clinical workflow. So the two topics I am also discussing day after tomorrow about integrating AI models in obstetric ultrasound. So this topic can overlap each other. There are some topics which I will discuss common. And so now my topic is interpreting artificial intelligence models in clinical workflow. So so we have already discussed about clinical relevance, then about relevance to modern, what is the relevance to integrating this AI to modern imaging practice, and why interpretation of this matters. And there are some interpretability techniques of these scans. And while interpreting these AI models, there are some national artificial intelligence policy that we have to take care of prior to integration and interpretation of AI models, and interpreting roadmaps. I'll discuss about this and challenges and future trends of interpreting these AI models. So coming this now, there is the different decades for this ultrasound and artificial intelligence. I think the artificial intelligence and ultrasound, the artificial intelligence can create a bridge between this point of care ultrasound and our, so it is called task shifting. So many researches nowadays are available in this artificial intelligence interpreting, helping to the non-experts for diagnostic purposes. So it is quite relevant to low and middle countries like ours, because radiologist in the peripheral part is quite scarce, and helping with this AI module can be a vast importance and can lower the morbidity and mortality of the patients in the periphery. So I think it is quite important to integrate and interpret AI models in clinical workflow. So why AI in obstetric ultrasound? As I've already said, there are high volume workloads in tertiary care center like ours as well, and there are volume, but there are no human resource. So that can be important, and uh, it is not every clinician knows how to operate ultrasound. So it is quite operator dependent. So there must be something that facilitates for the diagnosis of the patients for the periphery. So it is quite important. AI can take this task, and there is some it is quite operator dependent, as well as the diagnosis or the can be the operator dependent, so that diagnosis can be different from different clinicians. So there is need for standardization and efficiency. So it is one of the AI can literally help in this aspect as well. And as I've already said, there is immense capabilities to task shift these, and which can help in patient early management. So interpretation matters in clinical workflow. Yes, it does. And these three things can matter most while doing interpretation. One is clinical trust. Clinicians need to understand how and why an AI model arrives, uh, and he or she must trust its output. Another is the regulatory approval. The agencies like FDA require transparency, explainability for the AI tools for healthcare, and patient safety. Uh, and it can help identify the model errors, bias, limitations that could impact patient care. So while doing interpreting AI models into the clinical workflow, these three basic things must matter, I think. And there are, while interpreting these AI models in our clinical workflow, there are some barriers for this adoption. One is that the sonographic data are different from different, I think the diseases differ from geographic condition, and the data which is in the AI model from the western part of the world cannot fit in our part. So there can be there. And while doing this ultrasound images, there can be artifacts. So that artifacts can be really difficult to pick by AI. And there is technical proficiency of the practitioner as well for the quality of that initial ultrasound to fit into the AI setup. So, and there is uh, scarcity of the training data in this part of the world. And the and sometimes there needs to be a clinical judgment, medical context to come to the diagnosis. So this that can be difficult in the peripheral part of the world, because only relying on that image is sometimes more challenging. So it can correlate with the clinical judgment as well. So only the image, only diagnosing with that image can create some challenge, probably. So that these things are the barriers to adoption in this. So uh, these are the main things. And regulatory considerations for interpretation of AI models can be uh, uh, the FDA clearance and the European one, that products has met health, safety, or environmental requirements or not. And clinical validation and trials are also required for the interpretation. And the privacy compliance, protection of HIPAA, as well, or general data protection regulation must be taken care of before integration or interpretation of the AI models. So these are the some I found in the interpretation models. I think the you guys know more about than me about these interpretation strategies, model agnostic techniques. You can go through it. And other is model specific approaches like attention maps in convolution neural networks used in radiology, commonly used. And uh, other is the clinical validation. Then prospective trials should be required for the validation of these models. So in our clinical perspective, I usually, what are the techniques which we use for interpretation are image acquisition guidance. For example, if the novice uses the probe, the AI can guide the probe where you have to reach to get the ideal image. Like while doing fetal head scan, you have to go to the uh, plane of the biparietal diameter to say that we can measure in that plane. So probe can guide one thing, that is image acquisition guidance. And another is the if the image is uh, there, so that uh, AI can improve the image quality. Second, and third one is the if there is you reach to the proper plane of measuring the biparietal diameter, then you have to measure. So that measurement can be automated in many machines like GE nowadays. The automated measurements are available, and another is the lesion detection. So if it is normal or not, you can get through the AI model. And other is the workflow optimization, that is reporting and documentation can be done through AI. So interpretation, this basically, these five main things can be supported with artificial intelligence during our clinical workflow. So it helps in interpreting these five most. And this is the most important slide of this presentation, I think. So in these five sectors, AI can roll on, so that there can be uh, standardized images, good measurements, and lesion detection is also optimum, and there is reporting and documentation as well. So coming to image acquisition guidance, I have kept this example of long ultrasound, and there is and while doing the long ultrasound, the AI can guide the position of the probe, and going to the in this direction, the probe, the model can guide where the clinician have to do rotate the probe in that direction in proper imaging anatomical plane. So one is the image acquisition guidance. AI can help in interpreting this, and another is the improving image quality. Artificial intelligence, in this is the paper in 2020, I think, in fetal imaging journal. There is reduction of MRI artifacts, because while doing MRI, the fetus is we usually do fetal MRI in 21 weeks. After 20 weeks for fetal anatomy, if we suspect anything during fetal ultrasound in the commonly in fetal head, then we go for fetal MRI. And doing that fetal MRI, the artifacts are so common. Fetus is quite moving all the time because of the noise of the MRI machine or something. Uh, we can optimize that image with the help of artificial intelligence. And similar in ultrasound as well. If we get the some suboptimal image of the fetal head, you can properly outline that in 3D model as well, and in sometimes we do not get full length of the placenta during the fetal scan. So if we create that 3D um, 3D of the uterus and the placenta, it can help a lot to the clinician. So another is the automated measurements like this. If we get to the ideal plane for measurement, the machine automatically keeps show the measurements and the gestation age automatically. This is the G example of the current G machine. Current G machine shows uh, the biparietal and head circumference nicely, but not adequately like abdominal and the other femoral length. So till now, I have in my clinical practice, I see biparietal diameter is shown adequately by the available machines, but not the others. So we have to work on this as well. This is one of the genre to work upon. And the another is the nuchal translucency during the early anomaly scan. You can see this nuchal translucency. If you put the correct plane of the fetus, the machine automatically measures this nuchal translucency. So it is one of the aspects while doing interpreting through AI models. The lesion detection and classification, these are quite common nowadays. It is commonly done in breast, chest, X-ray, but not in obstetric ultrasound. So it is one of the new perspective which we can go into it to determine the fetal lesion or uterine lesion or the placental lesion, so that it is one of the mm, on it is not available in the our clinical setup in obstetric ultrasound, but it is available in X-rays, breast MRI, and other as well. And the lesion detection and classification nowadays we do in chest X-ray, like it is pointed by this colorful the nodule, and in CT also it is after this is the same CT of the same patients which we see in this X-ray. Nodule is detected by AI, and then going for the CT chest, the nodule is on the posterior aspect of the chest. Like this, in breast also, it is pointed by this square box by the artificial intelligence. So lesion detection is also one of the perspective we can think while applying the artificial intelligence model in clinical workflow. Another is reporting and documentation. Especially, I kept this slide because LMIC struggle in this perspective because we do not have our own PAC system in national level. But nowadays, in tertiary hospital in Kathmandu, we have internal PACs, which has which is nowadays easier, but not in the periphery. So there have to be an idea that we have a national PAC system, EMR, so that there will be a seamless data transfer, automated reporting templates can be there, so that it will get faster reporting from the clinicians. And this national data, which must be integrated within the hospital IT system. So then, really the hospital management in the LMIC can move upon with this reporting and documentation, which can be helped with artificial intelligence. So, and this why this PACS and EMR is important, because this can bridge the gap between medical imaging and patient clinical data, and there can be a holistic approach for the lesion detection as well in ultrasound as well. So there can be, and another is security and privacy, and the standardization across the country would help. And another is which can be done through AI, can be automated reporting templates as well, which can improve efficiency, consistency, reduced errors, human errors, and enhanced communication between the clinicians as well. So this can be done through AI. And these all can be integrated in the hospital IT system. There will be streamlined workflows. There will be, and eventually these all can help for the better patients care between. And this can help to communicate between two hospitals, to international, national level hospitals, local level, as well as it eventually it can better patient care. So Nepal also has this is preliminary, has national artificial intelligence policy drafted last year. They have explained problem, challenges, and need for policy in the national level, and they have identified certain problems for interpretation of AI in clinical workflow, like awareness, expertise, and barriers to data creation, and insufficient policy, shortage of skilled human resources in our country, and the ethical standards for AI are also some can lead to biased outcome. And they have these mentioned these problems for in during the policy drafting. And the challenge that there is challenge that use of AI remains within the ethical boundaries in LMIC, and the cost of the AI is also quite difficult for the LMICs to deploy in the peripheral part, and the collaboration coordination among various sectors is needed, which is a challenge. And there is sufficient skilled workforce is also a challenge in our setup. And what are the, and they have also outlined some of the opportunities of AI integration and interpretation in clinical or in the daily workflow. One is there will be enhancing productivity and service delivery in the sectors such as education, healthcare, and this can promote innovation through AI adoption as well. And this can determine the responsibilities and liabilities associated with that risk. And security, data security, and privacy is always a concern. So this can be also challenges and taken as opportunities for the country like ours. And they have also mentioned some strategies as well. for creating an environment for human resource production, capacity building, promoting studies for artificial intelligence, infrastructure development, managing data for AI development, and promoting the use. They have promoted the use of AI technology. So these are the short brief about our national AI policy, which was drafted a year before. So AI interpretation by clinicians mm, have to be clinicians have to be familiar with the model outputs, and there can be from the classification models which can yield probability scores or risk categorization, or the clinicians also should learn the model's performance, because we say AI as a black box on clinical perspective, but the clinician should know about its sensitivity, specificity, positive predictive value, everything, to be sure that he is fully aware about this AI, about AI interpretation as well. So for that, we need training and adoption. So it can be from data curation, annotation, and model development. Task-specific architectures can be done, and validation and testing, internal as well as external validation with some trials are also needed for training and adoption of AI models in clinical workflow. So challenges can be operator trust, and solution for that, the solution can be training and explainable AI. Second challenge could be data quality. That can be through standardized protocols with the help of AI. And another is workflow disruption. There can be a pilot testing, integration, iterative integration in the clinical setup, so that these challenges are solved. So how do we assure the quality of clinical interpretation of AI? That through periodic model validation, and some the blind spots or the unique cases can be separately pulled up, so that the AI model can learn during the process, and comparisons against human experts regular, it can be done. And the detecting and recording errors can be pulled into one, and there can be fine tuning or transfer learning can be there. So these things we can assure the quality of the AI products, and can in use for daily interpretation of the AI models. So ethical consideration are there. There is transparency in decision support, patient consent for AI assisted imaging. So patient consent should be there, and bias and fairness should be there to explainable AI. So AI models in our setup could be portable artificial intelligence enhanced ultrasound devices, which can be easily transportable, and it can promote remote diagnostics through AI, and supports telemedicine activities as well in our part of the world. So it can help diagnosis from the tertiary center to the rural setup, so that patient can be managed there. So AI can play a quite important role in these three aspects in our setup. So, and another, there must be bridging the gap between the radiologist or the obstetrician clinicians in our obstetric ultrasound with the AI developers and scientists. Both should be within one frame, within one sit in a table, so that and the AI developers can know the clinical needs, disease processes, image interpretation nuances, and then optimize the machine learning algorithm into their AI model, so that the AI model can be fruitful for there can be fusion of these fields, so that it finally the patients benefits. So future trends, federated learning for multicentral uh, studies can be there for the AI model, and multimodal AI integrating ultrasound, and correlating with that AI model ultrasound with labs and clinical parameters. Like I said, in preeclampsia, blood parameters and Doppler parameters can help, and predictive type of AI models can also help patients' outcome. So health records, like I said, with proper EMR or hospital IT system, we can analyze these health records, image analysis in depth, leading to better we can predict outcomes from the AI models interpretation. So this can be the future trend as well. So takeaways with this second presentation would be, we have to think of clinical relevance, and regulatory compliance and ethical oversight should be overcome, and there is multifaceted challenge. So AI scientists, researchers must work with clinicians for a better output. So there are level of evidence, and so these all step-by-step approach we can go towards on the top for clinical efficiency after mitigating these biases, general liability, data quality, AI model development, all these things. Eventually, we can move for proper interpretation of the clinical as well as image wise. So with big data, data training, AI technology, with the help of AI technology, it can enhance diagnostic accuracy during interpretation, and there can be personalized treatment plans. And another is telemedicine. So this whole can be integrated and interpreted so that there can be improved patient outcomes and with the optimized resources like ours. So currently, also one example what we are doing in TUTH in AI project, we are doing the fetal imaging AI project. One is blind eight sweep protocol, and we are doing with we are doing this blind eight sweeps, and finally getting the these sweeps out of the blind sweeps, and then we are uh, uh, building some models out of this, so that and it helps to get the information what we want and in correlation with clinical clinicians. So it can definitely help in future. And AI, there are a lot of things that AI can help in clinical workflow. So we have made one data mobile app also for creating this patient ID, which is anonymous, and we save the patient ID in the ultrasound machine, and we are annotating in this separate platform. So these are what we are doing this in to create some impact for the LMICs to decrease fetal and maternal modalities. So these are my references for this presentation. So thank you. Hope it is helpful.
All right, thank you so much, Dr. Pradeep. I'm seeing people really clapping, and I can see some questions that have come up. Kindly, I request that you all ask your questions now. I can see one question. In an ideal scenario, how should AI function for clinical trust? So this is in an ideal scenario.
In an ideal scenario, first model building is one of the most important aspect, because with the for proper interpretation and diagnosis, there must be proper ideal images. So with the help of the clinicians, what they want in the proper ultrasound image, and what the clinician want, what the information that clinician wants is the first step before uh, before getting the images for the AI model, and then creating the AI model. After creating the AI model in that setup, that must be used in that particular setup, because uh, the making the model in Western and coming to LMICs can differ in diagnosis. So in ideal situation, what we can do is sitting together, AI researchers, scientists, and clinicians, and then making one plan, and then integrate this clinical information into the AI model that can really build wonderful AI models for regular workflow, I think.
All right, thank you. I think, Saroj, you've gotten that answer. James, you asked the same question, which was you'd asked before about conical shape, and I think you're told it depends on the type of probe. You could get a rectangular shape if you use a different kind of probe. So James, kindly, I'm not sure whether you received that, but he had answered that. The next question is, what's the accuracy of the use of AI in ultrasound protocol slash model detection of abnormal pregnancy and ectopic pregnancy to reduce maternal mortality? So what's the accuracy like?
Um, Really, it is a good question, I think, because ectopic pregnancy actually it depends upon the setups. In our setup, what we do, we have an emergency setup and regular outpatient setup. So we get a lot of obstetric scans in the outpatient setups and only few ectopic pregnancy daily. So there have to be a large data sets to uh, to identify whether that uh, is really will work for making that AI model as well. So it is an interesting thought. We can study ectopic. There are some papers which have done, I think, two, three papers, I think, have done this study, but it is not so, accuracy is not so high enough. Probably because the itself ectopic pregnancy to diagnose ectopic pregnancy is to get fetal heart beating outside the uterus is so rare. Most of the time we get only a blood hematoma in the outside the uterus in a pregnant in urine positive pregnant mothers. So in view of that, it is quite rare to diagnose uh, uh, confidently ectopic pregnancy with uh, AI model in present scenario, but we can think of this project in a large, good number of years. We have to look the ectopic pregnancy scenarios because we do not get regularly the beating heart in the outside the uterus. Only we get the hematoma, bleed, some amount of collection in the outside uterus so that we suspect in correlation with clinical background.
Thank you. So I think Victor, that also asks, that also answers how we can go about building such a model. The
Mhm.
bigger issue being how much data you can collect.
Yeah,
So I
yeah,
can give you an
exactly.
example. For the Kenyan data set that you are collecting for ultrasound, we've done maybe about 850, close to 900, if I consider the practice scans. And we've only had one ectopic pregnancy, and it was
Exactly.
suspected ectopic pregnancy.
Mhm. That's
The
the
only
challenge.
way
Yeah.
they actually, after they did the scan and they suspected, then sent her to the ward. That's when now they found out that it was actually ectopic. So they couldn't even get the heartbeat, as Dr. Pradeep is saying. So it's very rare. Peter had his hand up. You can unmute and ask your question. Um, I think it was Peter. The hand went down, so I'm not sure what happened. Maybe they wanted to add something. Peter Anthony,
Mhm.
I think. I don't know that he's still there.
Okay, yeah. I was the one who raised my hand. I was trying to get clarity with the question that said, what is the accuracy of the use of AI in ultrasound protocol or model in detection of abnormal pregnancy? So I didn't get the question, so I could not get the explanation clearly
Okay.
because
Okay.
he was talking about detection.
Data. Data set. I
Yeah,
was
so
talking about the amount of data set we can get uh, in ectopic pregnancy. It is quite rare, and only most of the time you get the mother lined up with huge amount of blood in the abdomen or some amount of small collection like thing. So we cannot say 100% ectopic pregnancy because to call it pregnancy, ectopic pregnancy accurately, you have to determine the fetal cardiac activity in outside the uterus as well. So without correlating with the beta HCG and clinical parameters, it is hardly to get clearly the beating heart in the outside the uterus. So getting the data is quite challenging, I think, in this case. But if we get the data from the multiple partners, international setups, then we can do we can do this research as well. But accuracy is not high in present context.
Victor, you can go on before I
Yeah,
ask
thank
others
you.
to chat.
Yeah, good evening. Thank you very much, Aja. I'm asking. Am I audible?
Mm-hmm.
Yeah, okay. So my concern now is because we have a lot of issues, especially in the LMIC countries. So most of the maternal mortality rate that we have is as a result of late or non-detection. I remember some years ago while in India, you find out that most people, these people don't even know what the parameter or what they should do in order when there's difficulty in the pregnancy. So the question now is, in order for us to reduce the maternal mortality, which is a very serious problem, especially with the low medium income countries. With the introduction of AI, what parameters, what models can we introduce in order to detect deficiency in early pregnancy? Because if there's an early detection of abnormality in the pregnancy, that will at 50% reduce the mortality rate going forward. So what as scientists, as early career coming up, how can we train this AI model to build a model or a protocol to detect
Mm-hmm.
The mic is unmuted. Please mute.
Yeah, over.
Okay. I think probably the question was, please make me clear. What are the models that we can make in early pregnancy to decrease?
Yeah, what I'm trying to say, in order for us to reduce the maternal mortality death rate among now, the problem now is late detection. There is no early detection of this abnormality in pregnancy. So, as scientists, how can we train the AI model in order to detect early abnormality in pregnancy? Because if the women can be able to detect that there's a problem in their pregnancy, that will also help to reduce the problem. So, in what way can we, in order to train a woman like that?
In early pregnancy, which can decrease the maternal mortality in the later weeks, can be one, in my thinking, one, as you said, ectopic pregnancy, but it is challenging. The other one we can do is the congenital heart diseases in the 16 weeks of pregnancy. In most of the, we cannot see all the planes of the fetal heart in that early pregnancy accurately. So AI can build that model to detect the heart in different planes, so that we can also get 3D model out of it, so that it can help. The other could be in the talk I was also mentioned about that preeclampsia. And during that early second trimester, about 14-15 weeks, we do uterine artery Doppler study. But only with uterine artery Doppler study is not enough. We have to correlate between the between the blood parameters like the clinicians send like placental factors which takes a lot of cost for the patients. So if we can predict preeclampsia with uterine artery Doppler, it can be one important aspects during early pregnancy. So, and the other could be placenta, insertion of placenta, so that we can detect placenta, predict placenta accreta, percreta as well. So these are the 3-4 things which came into my mind in early pregnancy, so that we can prevent later maternal mortality and morbidity, I think. And in trimester, there is in early trimester there is another question from Mohammad Rehan. In which trimester we can identify that there are twins or triplets? So we can identify in early first trimester. So number of fetus we can identify clearly with AI in early pregnancy.
Is a question before that? How well the model may work fetal. Yeah.
AI mistakes are judged brutally, even they are performing better than humans. So yeah, AI models have done great, and there are mistakes probably because of the data set. Probably while creating the data set, there can be a human biases as well, and diseases change and because of change of geography, so that can affect the AI models with the wrong diagnosis. So we can change this narrative because from if we can build a model from international collaboration from the west, east, south, north, everywhere, so that the data can be generalizable. So it can help, and mistakes are bound to come if we are making anything new. So probably with better data and with better fine tuning the models, it can the accuracy will definitely increase. I think so.
All right, there's another one by Mohammed just above that.
How well the model may work? Yeah, definitely. Fetal echocardiography is one of the important perspective for AI, because I also do fetal echo regularly, and I usually come up with sometimes due to the fetal positioning, I could not get some uh, planes which I require to know the anatomy of the fetal cardiac structures properly. So if we can get the focus sweep of the fetal heart from chest, if the AI can build that model, that image into the different planes of the heart and with the 3D model, it can definitely help. So it is one of the important aspect that AI can build upon fetal echocardiography. So we can definitely do that.
Peter has his hand up. Sorry. Seems to have been muted.
Yeah, I was trying to ask, with respect to the question on early detection of abnormal pregnancies, though they may differ. How about, aside considering adopting, maybe adding some metadata and other additional informations, incorporating them in the system, aside that, how do you think about a system where you train a model where they may not be dictated early, but in the data, you try to take the scans, not current scans now. You take the scans at specific age stages, maybe early stages. Maybe they were detected in the 8th month, in the 7th month, but you start the scan, you take the scan, maybe you want at the first trimester, you take the scan. If you can predict future problem from the early scans, now
Okay.
you have many samples, but you have their scan for at 4 months, but they were dictated later on. Now, from the scans, you take them and predict, if you can predict from the early scan if there could be problem in the issue, or and with explainability, you could be able to explain why, if the such a model work well, you should be able to pinpoint areas why it is pointing that this will have problem in the future, and that could account for. I don't know if you get me.
Yeah, we can do that, because I understand that, because now a lot of works are going on preeclampsia, so they are doing on the works on early second trimester. But if we get the data from uterine artery Doppler from the earliest phase of the pregnancy, like 6-8 weeks, then we can carry on that. If we have data set from 8 to 16 weeks, for example, and then we of the same pregnant women who have preeclampsia later in the pregnancy, that definitely can help if we can build that sort of models in correlation with clinical parameters as well. So that definitely can help, and that is one of the new aspect you can work upon in the first trimester as well. So I think there are I haven't heard about the study worked on about 8 weeks of gestation for prognosticating preeclampsia. So only they have done work commonly after 13 weeks, 14 weeks. So they haven't done the work in the earliest pregnancy. So definitely that is one perspective you can work on.
All right. Thank you for that. I hope that answers Peter. Now, I know today's topic was a lot of obstetric ultrasounds, but very important for IT people, just to understand how everything is done and how it comes full circle, so that you're not just taking images and training, but actually understanding them. We've got one more question by Mohammed before the class is over. He's asking about how about the cord around the neck at term. Is there anything that can be done, I assume, with AI?
Yeah, about the cord around the neck, it is usually we count the number of rolls that the cord is going around the neck. If it is only one circle of the cord around the neck, then it is not clinically significant. But if it is more than two, it can be sometimes significant in late third trimester. So probably with AI model can detect cord around the neck, but it have to be more than one circle. So to make it clinically significant cord around the neck. So it is one of the common indication to do emergency cesarean section for in pregnancy. So it can one of the aspect could be detecting cord around the neck as well. But single cord around the neck is not quite significant nowadays.
All right. Any last questions? I think Mohammed is happy with that. Any last questions? So I'd like to really thank you for this session. We are really grateful for the session. I'm going to be uploading the recording possibly tomorrow. It takes a bit of time. Also, any additional questions, I will be putting up a question forum. For the questions from last week, I will put up a forum today that will cover for the whole of that week. I think I've done that. And then I'll also just prompt the facilitators to answer any questions that you put for them. So please keep checking the forums. You do have an assignment, work on that. And I believe the facilitators did give you a way of reaching them from last week. So thank you, Dr. Pradeep. We will have Dr. Pradeep again on Thursday.
Thursday, yeah.
Yep.
Thank you.
Together with another facilitator called Sukrit. So we expect you then. Thank you so much. And I wish you all a wonderful evening and night.
Thank you. Goodbye. Good night. Thank you for listening.
Thank you, Jim. Thank you. Bye, everyone.
Thank
Good
you,
night.
Victoria. Thank you, Pradeep.